A very good evening to all respected faculty members and dear delegates. On this Sunday evening, the IADVL ASPD webinar is the inaugural session of the Prime Presidential Project of Dr. Rashmi Sarkar, our IADVL President 2022, where we are bringing the expertise of these international experts right down to your drawing rooms. So, on behalf of the IADVL Leadership Committee 2022, on the behalf of the IADVL EC and the IADVL Academy, I, Dr. Surbhi Sinha, extend a very warm welcome to all of you to this webinar, which promises to be both educational and interactive. Today, we should be taking up two hot topics in pediatric dermatology, about the use of biologics in children and infantile hemangiomas. So these are two very, very trending topics, and we should all be extremely fortunate to have to be able to attend this because as we know, biologics are being now increasingly used in pediatric dermatosis, especially the use in inflammatory dermatosis, and infantile hemangioma is always a challenge. So I welcome Dr. Rashmi Sarkar, President IADVL 2022, to please give her presidential address, following which we shall have the two hot topic discussions. Dr. Rashmi ma'am, please.
So good evening, everyone. A very warm namaste. And to all our viewers also from India and from abroad, because we have members of the ASPT. Thank you so much, Dr. Surbhi Sinha. And I have to tell you right at the outset that this is indeed a great pleasure to present today's program, because this is a part of the presidential vision. In fact, the theme of IADVL this year is 50 years of IADVL. All of you are aware that we are in our 50th year, and it is about building future leaderships and international collaborations. A very good way of doing these international collaborations is getting some of our international dermatologist friend committees on board, discussing with them some of the diseases that they see in our country, and of course we see the same. So you will be having a host of these this year. You can look forward to a number of international society CMEs. You will also get to know what they're all about. And what better way to start than with something that I love and many of you love, and that is pediatric dermatology, something that I've been associated more than 2.5 decades now. And I thought that it's one of the societies which I really work with for a couple of years, and I've learned a lot, is the Asian Society of Pediatric Dermatology. And that is the best society today to bring up the CME. This CME, as Dr. Surbhi Sinha has said, is going to be in two parts. The first is about an interesting thing, that is using biologicals in children. Still, we have a long way to go, but we can learn. And second is on infantile hemangioma, something that I'm personally very interested in, since I have trained in one of the vascular anomalies department, that is in UCSF. Now, having said that, I'd like to thank that along with this presidential project, the IADVL EC has played a role of 2022, as this is an important Golden Jubilee program. So also the IADVL Leadership Pipeline Committee, which is again chaired by Dr. Raghunath Reddy, and the convener is Dr. Surbhi Sinha, whom you've just met. And she's, of course, also a member of the Education Committee of ASPT. We also have with us the help and assistance from the IADVL Academy, again, which is headed by Dr. Lalit Gupta and Dr. Rashmi Jindal, who's the convener. Regarding the ASPT, of course, we have the president is Dr. Sabira. And then, of course, this very dynamic secretary is Dr. Mark Kom from Singapore. Dr. Sabira is the president. And then, of course, I'm the vice president, and I'm from India. So this again is a very wonderful society to interact with. And I'm going to just show you a few slides regarding this committee. So are my slides visible?
Yes, doctor.
Okay. So the ASPT, or the Asian Society of Pediatric Dermatology, is a non-stock, non-profit organization of pediatric dermatological interest groups of Singapore, and neighboring Asia, devoted to clinical service, training and research in pediatric dermatology, as well as establishing linkages and collaborations and fostering camaraderie with other member interest groups. Our objectives are to provide a venue for exchange of ideas, best clinical practice, innovations, and updates among member countries. Also, to conduct research locally, regionally, and internationally, to promote international recognition of the societies globally, to establish linkages with other countries to promote the sharing of teaching and research facilities, opening venues for exchange trainings, residence fellows, exchange faculty, or dermatological practitioners, to establish accreditation, scholarships, fellowship grants, and awards to deserving members, faculty, practitioners, and trainees, to foster camaraderie among society members and colleagues, and to promote excellence in pediatric dermatological training and practice among member countries. Well, there are a lot of benefits of becoming a member, and the membership is free at the moment. Upcoming ASPD CME webinars, there's one on dermoscopy and pediatric dermatology on 18th May 2022. So these are the topics which will be covered: trichoscopy for common hair disorders in children, Dr. Samipa; dermoscopy for inflammatory dermatosis, Dr. David Look; dermoscopy for melanocytic lesions, Professor Giuseppe Argenziano; onychoscopy for nail conditions in children, Professor Bianca Maria Piracini. Then we have infestations and bites on 17th August 2022, autoimmune and autoinflammatory diseases 16th November 2022, and histiocytosis and mastocytosis 2023. Well, once you're a member, you get access to all these, and you have some of the best pediatric dermatologists from Asia as well as from the rest of the world participating in these. We also have a pediatric dermatology introductory course, a certification course to provide relevant knowledge and skills in diagnosing and managing common pediatric dermatology conditions. This is from July to November 2022. 5 modules, each with 2 to 4 hours of pre-recorded lecture videos that you can watch over 1 month at your own time. After completing the lectures, you're required to attend a one-line online live session where you can discuss the module content and allow for questions and discussions between participants and faculty. And certificate of completion will be awarded upon successful completion of this introductory course. So this, of course, is for family physicians, pediatricians, and general dermatologists. This is a very basic course. ASPD Hotspot is a blog featuring new cases regularly for members' discussion and sharing. The cases featured in these two segments are gray cases for discussion of diagnosis and management, and quiz cases, test your knowledge. So these are quite interesting. So you can share your comments and views again on the hotspot, which is there on the website. Then is the Asian Journal of Pediatric Dermatology. I'm one of the co-editors, and this Asian Journal of Pediatric Dermatology is a refereed and peer-reviewed journal of the Asian Society of Pediatric Dermatology. Only original manuscripts are considered for publication. Manuscripts must meet the goals of the journal, are reviewed by our editorial board consisting of a team of ASPD committee members. The AJPD is dedicated to publishing high-quality research in pediatric dermatology. Papers published by the journal represent important advances of significance to doctors within the field. These are the ASPD committees: Executive Committee, Education Committee, Communication, Sponsorship, Membership, Outreach, and Research. And Secretarial Team, and the GlobeWorks International is publication at asianpederm.com. We welcome you to join our membership, which is complimentary, and you get a lot of opportunities. You can attend the regional scientific meeting of pediatric dermatology, which is the RSMPD, at a discounted rate. The good news is the next one will be end of 2023, that is November, probably 17th to 19th of November, and that is going to be in New Delhi, India. So please stay tuned. Access to members only section of the society website, mentorship or further training within the region, and invitation to CME education events. So with that, I think, once again, I'm going to stop sharing the screen, and I'll once again give back, the mic, to Dr. Subhi Sinha.
Thank you so much, ma'am. Thank you for this introduction of ASPD, and thank you for the vision that you had of actually thinking of these international society CME programs, and for your help in putting this program together. So the first hot topic that we have today is the use of biologics in inflammatory conditions in pediatric dermatology. To deliver the talk, we have Dr. Leonkin Fon. He's the president of the Dystrophic Epidermolysis Bullosa Research Association. He's based in Malaysia. He's a very, very active senior member of the Asian Society of Pediatric Dermatology. We shall be having a recorded talk. He's going to be live for Q&As. And after the talk, we are going to have case presentations on the same topic by some very bright young residents and fellows. So I'm just going to be introducing them as well. Dr. Yang Su Cho is working at the National Taiwan University in the College of Medicine, Taiwan. Dr. Lee Wei Kuen, who's a pediatric dermatology fellow at the Women and Children Hospital in Kuala Lumpur, Malaysia. Dr. Henrietta Albella is also a pediatric dermatology fellow at the Women and Children Hospital in Malaysia. And Dr. Kathleen Gomez is working at the KK Hospital in Singapore as a pediatric dermatologist. So we're going to be having the recorded lecture followed by these case presentations, which will also have live poll quizzes and Q&As. So delegates are requested to please write down their questions in the chat box. We shall take them after the case presentations. And I request the Medinet team to please play the lecture of Dr. Leonkin Fon. No?
So please stay tuned for the quiz, for the poll quiz.
Yes, there'll be live poll quizzes.
Good evening, ladies and gentlemen. I'm Dr. Leong here from Women and Children Hospital of Kuala Lumpur. First of all, I would like to thank the organizing committee for their kind invitation. Next, I'm going to spend the next 20 minutes to illustrate the role of biologics in treatment of inflammatory dermatosis among children in the year of 2022. This is the outline of my presentation. First, I would like to go through the innate and adaptive immunity of our skin so that we can understand further about how to choose the right biologics for a specific inflammatory skin disorder. This is our skin. First, our skin have a strong physical barrier, contributed mainly by the stratum corneum, the tight junctions. We also have a layer of microbial barrier, contributed by high biodiversity of a skin microbiota. We have a chemical barrier of pH of around 4 to 5.5. We also have the toll-like receptor, antimicrobial peptide that produced by keratinocytes, and also the cellular component of the innate immunity, the macrophage, eosinophil, basophil, mast cell, and neutrophil. There's another new group of cellular component of innate immunity called innate lymphoid cells. The ILC type 2, closely related to atopic eczema, and the ILC type 3 related to psoriasis. We have the messenger between innate and adaptive immunity. They are our dendritics. In the epidermis, the upper part, we have Langerhans cells. And during inflammation, we have the IDAC, also the plasmacytoid and myeloid dendritic cells. These are the messengers that present the antigen in the lymph node to naive T cells. They are the messengers of what is happening outside and present to our adaptive immunity. Under different cytokine microenvironment, these naive T cells will proliferate, differentiate into different type of T cells from Th1, Th2, Th17, and Th22. Now we have Th9 and Treg. So these cells, they communicate with each other with different languages. For example, Th2, they produce IL-4, 5, 13, and 31, and that's involved in the communication with other cells. The Th17 produce IL-17 and 22, and many other languages used in different cells. So bear in mind that this communication is not one way, it's a positive feedback loops and a lot of crosstalk among these cells using different cytokines and chemokines. So this complicated traffic is organized under certain major pathway. Thanks to the combination of phenotypes, histological and genomic study, and proof of concept study have identified at least 5 important pathways that contribute to some of the skin disorder in children. Which are the 5 major pathways? The first pathway is the IL-23 Th17. The second is our IL-4 Th2 that produce IL-4, 5, 13, and 31, the main cytokines that contribute to atopic eczema phenotypes, further supported by the Th22. And before this, we thought the central pathway of psoriasis is IL-12, Th1. Now we know it's the IL-23, Th17 axis. And the generalized pustular psoriasis is related closely to IL-1 and IL-36. All these pathways, they do not perform individually, but they have a lot of crosstalk involved in regulating the innate and adaptive immunity. Once any of these get dysregulated, they will manifest with one form of inflammatory skin disorder. Let us take a look at the first inflammatory dermatosis in children, which is atopic eczema. Atopic eczema is a well-known Th2-mediated inflammatory skin disorder. And over the last decade, studies have shown that besides Th2, Th22 also play an important role, especially in the epidermal hyperplasia part of atopic eczema. Besides that, there's a variable degree of infiltration by Th1 and Th17 according to different ethnic group and chronicity. During the acute stage, many Th2 and Th22 infiltrate the lesional eczema. And during the chronic stage, there's intensification of Th2 and Th22 and variable degree of infiltration by Th1 and Th17. Among the European, American, and East Asian, both Th2 and Th22 heavily infiltrating the eczemated skin, but with variable degree of Th1 and Th17. Th17 is more prominent among the East Asian eczematous area. These are the topical and systemic anti-inflammatory agents used to manage patients with atopic eczema over the last 7 decades. It's exciting to learn that dupilumab is approved for children more than 6 years old with moderate to severe atopic eczema. When we prescribe dupilumab to a child with moderate to severe atopic eczema, these are the 4 commonly asked questions. Firstly is the efficacy. In terms of efficacy, we are not asking for efficacy at 16 weeks. We are looking at how rapid is the onset and sustainability, not for 16 weeks, but 1 to 5 years. Because we all know that atopic eczema is a chronic relapsing disease for years. And thankfully, dupilumab fulfilled the criteria, has a rapid onset. By 16 weeks, about 53% of them achieve EASI-75 among children between 6 months to 6 years old in the Liberty and the Infant and Preschool study. And about 7% of them, after a single loading dose, achieve EASI-75, about 1/3 by 4th week of treatment. And this treatment response is significant statistically compared to placebo, 11% at 16 weeks achieve EASI-75. Based on our observation, those have a rapid onset, require a shorter treatment regimen are those with mild lichenification. Although they might have extensive body surface area affected, high EASI and score, but the skin have less lichenification. For this group of patients, although they have very severe itchiness in the first few weeks, many of them do improve significantly over the first few doses of injection. And this child, within first dose, have achieved score and itch reduction by around 75 to 80%. On the other hand, those with severe lichenification, prolonged progressive clinical course, these are the difficult ones because it takes time to reverse the disease progression, especially among those with significant lichenification. Although in our EASI score, there's a significant improvement, but in the eyes of the caregiver, the child still could not sleep at night after 16 weeks. So fortunately, we hold their hand, we explain to them that those lichenified area, it takes time to be reversed. And similarly, it takes time for us to fine-tune the dysregulated immune system and repair the skin barrier defect. Over the next 32 weeks, you can see the child condition improve significantly from IgE4 to 1 to 2. And subsequently, at 52 weeks, the patient had achieved EASI-90. So bear in mind that dupilumab, just like other conventional treatment strategy, education and empowerment is still the key to successful treatment regimen. So besides looking at EASI-75, we also look at the itch scoring system. So many parents expect itch control over a short duration of time. About 2 weeks after loading dose, there's a reduction in itch by 21%, and at 16 weeks, about 49.4%. Sometimes it's very difficult for us to appreciate what does it mean by itch reduction by 50%. And for the patient, they are very grateful and they really can feel the treatment response. See this child, there's an itch reduction by 50%, scored by 30% only, but the personal happiness index improved by 150% at 8 weeks and at 32 weeks. And the child described this as a life-changing event, from a sorrowful appearance to a laughing appearance over a duration of 52 weeks. At this point, the child described his life is on cloud nine. Now he can jump, he can play, he can swim, he can eat, he can wear short sleeve in his own way. From how rapid is the onset of actions, next we move on to sustainability. As mentioned just now, atopic eczema is a chronic relapsing disease that waxes and wanes for years, on average maybe 5 to 10 years. So EASI score 75% reduction at 16 weeks is too short to represent a chronic disease. And based on the study, the Liberty, AD, infant, preschool, and pediatric, from 6 months to 11 years, the EASI score at EASI 75 at 16 weeks is impressive. It's 53% for the preschool and 69.7% for children between 6 to 11 years old. As mentioned just now, this is not sufficient. We want to have a data on after a year or even up to 3 to 5 years. So based on my personal experience in Hospital Kuala Lumpur of 20 patients, severe atopic eczema between 6 months to 12 years old, about 75 to 80% of them achieve EASI 75 at 16 weeks. Of course, this is important, but it's not sufficient to guide us what to do after 16 weeks. So we are waiting for the open label extension study. They are recruiting patients now. But before that, we have an interim analysis by Professor Michael Jacob have shown that we need to persevere long enough. In fact, in his study, it's safe, it's effective, and the efficacy is cumulative throughout the 52 weeks. As adults started using tupilumab in 2017, they have longer clinical data. So this is the first study up to a year. Liberty AD Chronos showed that the efficacy is sustainable all the way from 16 weeks to 52 weeks, and subsequently Lisa and Beck et al. Have shown that efficacy is sustainable up to 3 years among adults. In my center, out of 20 patients with severe atopic eczema, only quarter of them we managed to off tupilumab to topical after 24 weeks. The rest need either continuation of tupilumab or we switch to conventional systemic therapy. And the side effects, most people agree that tupilumab have a very good safety profile. About 5 to 10% of them might have adverse event affecting the eyes with conjunctivitis, and some complain of injection site reaction, but most of them are short-lasting and no need to discontinue the treatment. And among the 20 patients under my care, about 5% of them develop conjunctivitis, 10% develop injection site reactions, but mostly are transient. And this one, my child with conjunctivitis, I reduced the dose to 200 milligram monthly regular artificial eye drops, and still eye drops require only about 2 to 3 days in a month. Managed to control the conjunctivitis and continue treatment with good treatment response. From atopic eczema, next I would like to move on to plaque psoriasis, another chronic inflammatory skin disorder in children that mediated by Th17, Th22, further supported by the cytokines from Th1. So these are some of my patients with severe plaque psoriasis. They are kids on biologics. So which biologics, for how long, and how to administrate, all are based on shared decision between medical team, the caregiver, and the patients. And we need to tailor and individualize them based on these few parameters: the efficacy and sustainability, the safety record of the biologics, the local policy, what is the age of approval, the cost of the medication, how frequent we need to inject the patient, and associated comorbidities. So these are some of the important factors that will affect the final choice. Based on the efficacy and sustainability among biologics approved for children, secukinumab is superior to ustekinumab and etanercept. And this is one of the most recent study using etanercept, secukinumab of different dosage, and placebo to assess children between 6 to 18 years old with underlying plaque psoriasis. And this is a phase 3 double-blinded randomized study. At week 12, 80% of the patients on secukinumab achieve PASI 75 and 30% achieve PASI 100, whereas those on etanercept, 63% of them achieve PASI 75 at week 12 and 17.1% achieve PASI 100. And this one of my patients, a 10 years old girl with severe plaque psoriasis, she developed depression because of the underlying plaque psoriasis that not just affect her back, but also affect her face, and partially responsive to 6 months of methotrexate. So shared decision, agreed to start on secukinumab. Her psoriasis improved dramatically and she achieved PASI 100 at week 12. As psoriasis is a chronic inflammatory skin disorder for years, So efficacy study up to 12 weeks is not sufficient to guide us how to manage plaque psoriasis on long term. So this study extended to week 52. Again, both etanercept and secukinumab has sustained efficacy all the way to from week 12 to week 52. For those on secukinumab at week 52, around 90% of them achieved PASI 75, and for those on etanercept, 68.3% of them achieved PASI 75. And this is another patient, an 11 years old boy, severe plaque psoriasis, again partially responded to acitretin. Again, with shared discussion and decision, we decided to put him on secukinumab at 12 weeks. He achieved PASI 75. At week 52, he achieved PASI 100. So besides efficacy and sustainability, safety profile, whether it's off-label or on-label, are other important factors. Among the biologics approved for children, etanercept has the longest track records. And about their age of approval, EU has approved etanercept adalimumab for children more than 4 years old, and for IL-17 and IL-23 inhibitors is for children more than 6 years old. Given that biologics therapy are administered via injection because of the large complex molecules, so less frequent dosing is often preferred by the patient and the family members. That's the reason why we seldom use etanercept because of the weekly injections, and in my center, our first choice either secukinumab or ustekinumab. Of course, the local guideline and the cost of medication are some of the very important factors that will affect our final choice. Let us move on to another papillosquamous inflammatory skin disorder in children. It's true that PRP is less common compared with plaque psoriasis among children, but it does cause profound impact on the kids that develop PRP as much as among those that develop childhood psoriasis. One of the similarity between plaque psoriasis and PRP is the major pathogenic pathway is the IL-23 Th17. This is supported by a case report by Familiar et al. In 2018, have shown that over the lesional area, there's an elevation of the IL-23, IL-17, IL-22, and TNF-alpha. Further supported by the cytokines from the Th1 and interferon gamma. There's no detectable IL-4 over the lesional area. So this is one of the reports that provide a rationale for targeting the IL-23 Th17 pathway as a treatment option for those that not responsive to acitretin and methotrexate. How about the track records of using biologics in childhood PRP? Up to 2018, only 4 cases documented using different types of biologics, including ustekinumab, etanercept, adalimumab, and ifalizumab. And all 4 cases demonstrated significant improvement within the first 2 to 3 months of treatment. Of course, there are more study case report of benefit of IL-17 and 23 inhibitors in adults, but the data is still limited to case report and case series. There's a systematic review of using ustekinumab. 10 out of 16 means 2/3 of them treated with ustekinumab have a good response, and average time of the therapeutic response is about 6 weeks. Another open label study on 12 adults treated with izokizumab, about 58% of them achieve at least 50% reductions. I do have a child recently, about a year ago, with infantile onset PRP. We did send for CAT14 but are unable to identify the CAT14 mutation, and this is atypical juvenile type 5. And this girl suffered from itchiness related to her underlying PRP, and the thickness of the palmoplantar keratoderma did disturb his daily functions, especially the fine motors. After 3 years of observation and a year of systemic treatment with acitretin, there's no sign of regressions noted. So, share decision with the caregiver, we decided to put the child on secukinumab, and this is after 4 doses every 4 weeks of 150 mg secukinumab. There's a significant improvement up to around 80 to 90% in terms of reduction of itch, erythema, scaliness, and thickness of the palmoplantar keratoderma. So this is one of the good options, especially for those that are not responsive to traditional systemic medicine like MTX and acitretin. From atopic eczema to plaque psoriasis and PRP, now let us move on to the 4th childhood dermatosis that might benefit from early biological therapy. And this condition is congenital ichthyosis. I believe among these 4 group of conditions, congenital ichthyosis is the least expected one to be one of the biologics responsive dermatosis in children. because as we look at the congenital ichthyosis, often we look at their primary keratinization disorder. We focus on the thickness of the scales, we focus on the dryness. If thick enough, they might form painful fissures and cracks, but we often neglected the underlying inflammations. When we look at congenital ichthyosis, clinically often they have two components. The first component is how thick is the scales. For example, in laminar ichthyosis, often they have thick brownish armor-shaped scales on the skin. Whereas for harlequin babies, they have both. And in ARCI with congenital ecdysiform erythrodermal and Netherton syndrome in the first few years, often they have prominent erythema with small little scales on top. So among these four phenotypes, those with minimal erythema like laminar ichthyosis are the least responsive to biologics therapy. So based on current lesional analysis have shown that among children with ichthyosis with underlying erythrodermic, often they have significant inflammatory infiltrates in the dermis. And when you analyze the cytokines profile, most of them resemble psoriasis. So these are driven by Th17, Th22 with a positive feedback loops with the IL-36 from the keratinocytes. So this is one of the study by Malik et al. Shown that the molecular fingerprinting among patients with congenital ichthyosis show profound Th17 skewing, and this resembling those seen in the patient with psoriasis, further supported by the psoriasis vulgaris fingerprint, and there's a most significant overlap between psoriasis and ichthyosis, together with upregulation of the IL-17. This formed the rationale of using IL-17 inhibitors in managing those patients with congenital ichthyosis and prominent erythema. And this is one of the ongoing randomized double-blind phase 2 clinical trial using secukinumab in adults with congenital ichthyosis over a duration of 16 weeks. We are looking forward for the results so that will guide us which subset of patients with congenital ichthyosis might benefit from early biological therapy. In my center, we also have two cases of congenital ichthyosis treated with secukinumab, and this one case, an 8-year-old girl with ARCI secondary to ABCA12 mutations, and she complained of loss of skin elasticity. You can see that she developed atropium with prominent erythema, itchiness, and scaliness. After 6 doses of secukinumab, she has significant improvement, more than 60% in all these parameters of redness, scaliness, and improve in elasticity of the skin. See her atropium improve, and even her back, the itchiness improve, scaliness improve, as well as the redness. The thick scales of the keratoderma over the palm and soles has improved after 6 doses. The final condition that I would like to go through today is generalized pustular psoriasis. In GPP, the main pathway that affected is the activation of the IL-1, IL-36 signaling pathway. There are many forms of psoriasis, from plaque psoriasis to paradoxical to pustular psoriasis, and this all depends on the fine-tuning of the innate and adaptive immunity, and that determine the onset, cause, and the type of psoriasis. In pustular psoriasis, it's mainly affecting the IL-1 and IL-36, whereas in the classical plaque psoriasis, it's mainly affecting the IL-23, IL-17. In terms of treatment, in my setting, the first line is oral acitretin followed by cyclosporine. If they are not responsive, then I'm going to discuss with the parents about the role of IL-17 inhibitors. It could be secukinumab or ezekizumab. Of course, a more specific one is IL-36 antagonist, but currently it's still in phase 2 study. In the interest of time, I would like to wrap up my lectures by sharing 4 cases from my center with GPP treated with secukinumab, published last year in Journal of Dermatological Treatment. Among them, one of them with IL-36RN mutation, and within a month of treatment, all of them achieved GP PASI 90 to 100%. And this is one of the patients after 1 week, after 6 months of treatment, and now about 24 months now is still under remissions. With this, I would like to end my presentation. Thank you very much for your attention.
Thank you, Dr. Kinfon. Bharat, can we now play the case presentation videos by the residents and fellows? After which we shall have the discussion.
Yes, doctor, it's live. First is Dr. Young.
Yes.
Yeah.
Yeah, I think meanwhile, I'll also ask people if you have questions, please do send your questions because we are going to be taking up questions at the end of, these sessions. Please keep them ready so that, I can ask these questions after these 2 or 3 cases.
Dr. Leong, please go ahead.
Okay, good evening, everyone. I'm Yong Zhou from Taiwan. Today, I'm glad to share my case. I should be from the start.
Dr. Slideshow mode, please. Yeah, thank you.
Okay. Good evening. This is a 13 years old boy. He has a long history of allergic rhinitis since his very early childhood. And about 4 to 5 years ago, he started to have very itchy, pruritic skin lesions on the trunk and limbs. And these lesions are very troublesome to him and would interrupt his daily activity, learning, and sleep. And let us see the lesions. We can see many pruritic, excoriated papules and nodules on his neck, back, limbs, and abdomen. And these lesions usually wax and white and cause him very difficult to focus and concentrate on daily work and learnings. So we have a first poll questions. If this patient come to your clinic, what is your preferred first-line treatment for this case? Number one is topical potent corticosteroid. The second one is intralesional injection of corticosteroids. The third one, cryotherapy, phototherapy, systemic immunomodulators, or biologics.
So is the poll on?
It's on, doctor. Yeah.
Okay.
Dr. Young can give about 8 to 10 seconds, and then we can move to the next question.
Will you put the answers on the chat?
Yeah, sure.
I think I can see the poll results.
I think Bharat, you can tell them, when the results come in, that is better.
Okay. So we move to the next questions. I think usually the first line treatment may be not good enough for this case. So if you see this patient and he failed the first line treatment, what will you prefer next treatment for this case? And the same answers for these 6 choices.
Bharat, can you please tell us once the answers come in, can you just display that or read it out for us? Because he will not know otherwise.
Yes, doctor. I'll just put in a Zoom chat box.
Yeah, once he gives you the answer, Young-Soo, then you can just give the answer.
Okay. So my choice is use the biologics dupilumab for this case. We can see after 16 weeks of treatment, most of the prurigo lesions improve and become flattened after 4 months of treatment, and the patient suffered no more pruritus sensations. And we see, let's talk about the prurigo nodularis. This is a chronic condition usually caused by the inflammations, and The most important is that in lesions of prurigo, there are increased density of dermal nerve fibers. So these patients usually feel intense itch, and they usually can control their behavior to scratch lesions and cause aggravated inflammations. So the most important, I think the most important part to control disease is to control the pruritus and also control inflammations. So I have two questions for panel discussions. The first one is, how do you manage pruritus in these
Sorry,
patients?
Youngsu, the answers have come on the chat. Can you see them? Then you can give the correct answer. The answer is there on the chat.
I can see the answers. So the first poll question is the preferred first line treatment. I see 53.1% they choose topical potent corticosteroids as the first line treatments, and about 28.1% they choose systemic immunomodulators as the first line treatments, and no one choose cryotherapy as the first line treatments. Okay, so I just share the result of the poll one. And we just wait a moment for the poll too.
Yeah, he's just getting the second poll.
The second poll. Okay, I see the result of second poll. When patients fail the first line treatment, the second preferred treatment is, I think the most patients choose the biologics as the first line treatment, about 25.6%, and followed by intralesional injection of corticosteroids, about 23.1%. Then the third choice is systemic immunomodulators, about 20.5%. They choose the next treatment as systemic immunomodulators. And the same, only 2.6% they choose cryotherapies. So here's our poll results.
So you can give the answers now, Youngsu, for both the real answers.
My answers?
Yeah.
Yeah, I think as the result, my first line choice is a potent topical corticosteroids because it's still effective in some patients and usually do cause no pain for the patients, not like cryotherapy or intralesional treatment. And also it causes no systemic side effects. And if these patients fail the first line treatment, the next choice for me is the biologics. So I just choose the dupilumab for this case.
I'm Leong here. I will agree with John as well. My first line is very potent. Ultra potent topical corticosteroid with wet wrap, especially in children, because intralesional is a bit too aggressive initially. And I would like to move on then to systemic treatment. In my center, our first line is cyclosporine, followed by methotrexate or azathioprine. Of course, cost is not an issue. Then even my center also will start dupilumab once we have 3 months of one of the conventional treatment fails. We don't wait too long because the prurigo nodules is very, very itchy. And of course, last thing that I would like to highlight is don't rely on non-sedating antihistamine. A lot of people, they just give super high dose and hoping that they will take care of the itchiness. And as we all know, in itch mediator in atopic eczema is much more than histamine. They include others like IL-31, IL-4, 5, as well as others, TRPV1, etc. Mark, what do you think?
Yeah, Mark here. I agree. I totally agree. I mean, first line is always potent topical steroids first. In addition to what you've mentioned, we also do give quite a bit of phototherapy, and I find using both UVB with UVA together sometimes works better than just narrowband ultraviolet B for these thicker prurigo nodules lesions. And you're right. I mean, nowadays with the biologics, the Dupilumab, I think we probably are starting a little bit faster for these patients, as long as the cost is it's affordable. I think hopefully with nemolizumab coming up soon, that's the IL-31 blocker. Hopefully, that will give us more armamentarium against these prurigo nodules, which are, extremely itchy. So IL-31 is supposed to block more of that itch. The other thing that I also recommend sometimes in these patients is that, they scratch because either they're stressed or they're bored. So we do get our psychologists in sometimes, to teach them distraction techniques as well. Yeah, so totally agree with everyone. Shall we move on to the second case?
Yeah, I think let's move on. Let's do the cases.
Right.
Then we have a couple of questions. We'll take them up then.
Okay.
After the cases.
Okay. Shall we present the second case? Thank you, Dr. Young.
Hi, I'm Lee, and I'll be sharing a case on recalcitrant atopic dermatitis. This is my patient and how she looked like when I initially saw her. She is a 13-year-old Malay girl who has severe atopic dermatitis and comorbid of allergic rhinitis, which is also a type 2 inflammatory disease. At age of 9 years, she was treated for moderate atopic dermatitis with topicals. She had multiple exacerbations due to cutaneous fungal and bacterial infections. At 11 years, she was commenced on azathioprine for worsening atopic dermatitis and referred to our center for further care. She had multiple erythematous, dark brown, scaly, and lichenified plaques and nodules. She subsequently defaulted azathioprine and followed up due to the COVID pandemic. At that time, the EASI score was 24.9 and SCORAD was 54.2. So this is our first poll question. What is the next step in managing her severe eczema? So you have about 10 seconds to answer this question. So either we restart azathioprine as she had some improvement while on treatment. We should choose another systemic immunosuppressant such as cyclosporine or methotrexate, or consider starting biologics such as Dupilumab, or continue potent topical corticosteroid. We shall close the poll for this question now. So a few months later, she was started on oral cyclosporine. She continued to have flares, and a year later, she developed hypertension. As we can see here, she had little improvement from cyclosporine, and the lichenified plaques and nodules were severely itchy and affecting her sleep. Here are more photos of her lichenified scaly plaques with evidence of both acute and chronic inflammation. Her eczema remained severe with an EASI of 29 and SCORAD of 58.9. We are now at the second poll question. In view of hypertension, what should we do next? A, stop cyclosporine and consider methotrexate. B, reduce the cyclosporine dose and repeat the BP in 2 weeks. C, withhold cyclosporine altogether and restart when it normalizes. D, reduce cyclosporine and start biologic. E, off cyclosporine and start biologic. You have another 10 seconds for this question.
So I think he'll come back with the answers, White Queen. Bharat will just show you soon the answers. So you
I
want
put
to
the
wait
answers,
or
ma'am.
you want to go? You have?
Yeah.
I think he's...
The first poll question, the answer was to start cyclosporine. That's 100% actually. So there's no other answers.
Okay, that's a lot.
So for the patient's progress, Cyclosporine was subsequently reduced and tapered off, and the child was put on dupilumab 600 milligrams loading with 300 milligrams every 4 weeks. And this is how she looked like at week 8 of treatment with dupilumab. We can see here that the lichenified and scaly plaques on her chest resolved with post-inflammatory hyperpigmentation. The dark brown plaques and nodules on her lower limbs were also resolving with this pigmentation. So we can see here, this is the table that shows the progressive improvement of her EASI scores, numerical rating scale for her each sleep loss and after starting dupilumab. We can see here the numerical rating scale for each improved more than 50% at week 4, and she attained EASI 75 by week 12 of treatment. This randomized trial showed that dupilumab significantly improved atopic dermatitis signs, symptoms, and quality of life in adolescents with moderate to severe atopic dermatitis. My points for panel discussion today are, should dupilumab be used once patient had failed topical therapy? And secondly, if the patient had good response with cyclosporine but develops hypertension, should it be reduced or stopped altogether? So this is the end of my presentation, and thank you.
Thank you, Dr. Lee. Another interesting case, Kin Feng Ayon. Yeah. So I think cyclosporine, I feel, it works. I like to give cyclosporine when they are, sort of more acutely, more severe kind of thing, getting a flares and all that. But in the long term, I think we are always a little bit concerned about the side effects with the renal and the hypertension as well. So I usually try not to go beyond a year. Yeah, I think with with the biologics, our use is so much more now. If the price comes down, I think biologics are going to become first line very soon. Kin Feng, your views?
Yeah, I think cyclosporine, if I look at the patient, I have a confidence that I can induce remission within 6 months to a year, then that's a very good option. We do see very dramatic improvement with cyclosporine in the first 6 to 2 months. And these usually are more responsive for those with minimal lichenification. We know very well that when the patient has significant lichenification, it takes a couple of years to reverse the process. So I think when it comes to dupilumab, it's a much safer option for long term. Hopefully, it can reverse the progressions of the lichenified eczema.
Yeah, and I think with the newer biologics coming on, tralokinumab, and ebrikizumab, I think hopefully we have more options.
More options.
In fact, I agree with both of you. I think it's mainly the price factor, because if that also is covered and all in India, I think you'll have dupilumab, the newer biologicals, which should play an important role. Until then, of course, we do use a lot of cyclosporine in our practice, at least for atopic dermatitis.
Yeah. With the hypertension, I mean, I don't see it that often with cyclosporine, but if we do detect it, we do reduce the dose first. Unless it's really very high, then we'll stop it.
Yes, absolutely.
Yeah, and I tend to, sometimes when they are cyclosporine, if I start them on dupilumab, I do slowly bring down the cyclosporine rather than take it off immediately, unless there's a side effect. Yeah.
I think there's a very important strategy for whatever systemic medication. We should not stop abruptly for either one of them. Even dupilumab also, if let's say after a year, we do have budget to continue, we need to have an overlap with another conventional treatment before we off it, instead of stop and see. And we know very well that if lichenified eczema, that tends to come back again, even though you have dupilumab on board.
I think there was a question on maximum duration of dupilumab. I don't think there's a maximum duration now. We go on until they're much better, and we try to reduce it to a comfortable level.
Yeah,
I think the trials have gone on for like 8-10 years already, and some patients are still on it. Yeah. Okay. Shall we move on? Thank you, Dr. Lee.
We should go to the next.
Very interesting case. Can we move on to the third case? Thank you.
Hi, I'm Henrietta. Today I'll be presenting on biologics in generalized pustular psoriasis. Here I have a 5-year-old Chinese boy who presented with generalized pustular lesions since early infancy. Skin biopsy done was consistent with pustular psoriasis, and whole exome sequencing revealed a homozygous mutation within the IL-36RN gene. So on examination, he was small for age. There was 90% involvement of his total body surface area. There were erythematous papules, plaques, and pustules with tendency to coalesce, with scaliness and exfoliation. His GPP area and severity score, which is a modified PASI score, was high at 36.9. Systemic examination was unremarkable. So he was started on oral acitretin with intermittent courses of low-dose prednisolone since infancy. However, this was complicated with transaminitis. Subsequently, it was changed to oral cyclosporine of dose 3 mg per kilo per day, and he had concurrent topical therapy. And despite optimization of therapy, his GPP was still suboptimal control, and he had frequent flares, usually precipitated by infections. So our poll question, what will be the next step of management for this patient? A, continue and increase dose of oral cyclosporine. B, restart oral acitretin. C, start oral methotrexate. D, consider starting biologics. Or E, switch to phototherapy. We will give you 10 seconds for this poll.
I think approximately maybe 15, 20 seconds would be okay, Henrietta. I think you're getting little more responses then.
Okay, sure.
Yeah, okay.
So if we can get the poll answers up, please.
Yeah, I'm looking for that.
Yes, doctor, it's in the Zoom chat box.
Yeah, have you put it? Okay, he has just put it in the Zoom chat, Henrietta.
Yeah,
Can you have a look?
so the biologics, 83% would consider biologics and 17% would consider phototherapy. And so the progress of this patient, in view of suboptimal response to acitretin and cyclosporine and complicated with transaminitis, and considering the fact that he has a positive genetic result in which he has a homozygous mutation within the IL-36RN gene, he was started on off-label use of subcutaneous secukinumab, to which parents agreed and consented to, and subsequently achieved complete remission. And if you can see serial photos of just when he started, and subsequently within few injections, we were able to achieve complete remission for him. So a short discussion, GPP is a severe form of psoriasis, and a subset of these patients have IL-36RN mutation. A study among the Chinese population demonstrated that patients with GPP subtype exhibited the highest mutation rate of IL-36RN, in particularly this mutation, which is the same one that our patients had. Most commonly used systemic medication for first line, including acitretin, cyclosporine, and methotrexate. The anti-IL-17A monoclonal antibody secukinumab has been shown to have rapid improvement in adult GPP patients. And just a brief diagram comparing the pathogenesis between GPP and plaque psoriasis shows that there is cytokine crosstalk between these two pathogenesis. In GPP particular, where IL-36 is the main interleukin, it's also induced by other pro-inflammatory markers such as interleukin-1, TNF-alpha, and interleukin-17A, which would explain why secukinumab will be effective in GPP as well. So points for panel discussion. Number one, what is the treatment algorithm for GPP in children? Because considering GPP is rare and there is no specific guidelines. And two, ideally, should biologics be the first-line treatment in the management of severe GPP in children, especially those with a positive genetic result? With that, I end my presentation. Thank you.
Thanks, Dr. Henrietta. Very interesting case, and again, very impressive results with the secukinumab.
Yeah.
So
what do you think, Mark? In your center, what is your first line now?
we still do acitretin, cyclosporine. I find once they come into us, usually it's of course flaring in the first flare, right? Course of oral steroids with acitretin, I find is probably brings it down really fast. But of course, then how high can you go with the acitretin before they get side effects? So biologics, I guess, in the past we used to give the TNF inhibitors, but now with secukinumab, I think that's probably the way to go. But again, cost is an issue. it's shown to be quite safe. So I think safety-wise, it's definitely safer than the TNF agents.
Yeah, based on my observation, my cohort of patients, those without genetic results, means without the mutation, that tends to run a 1 to 2 flare a year. Those are much easier to manage. Means they have only one flare after maybe viral infection vaccinations. For this subset of patients, we do manage to control them with just acitretin and cyclosporine. But they are the one that with a genetic mutation, IL-36RN, CAT14, they have tendency to have very early onset, very progressive and persistent disease. Those group we find is not possible to control just by acitretin and cyclosporine because we are talking about lifelong. It's not 1 or 2 years. I don't know whether do you have that observation, Rashmi or Mark?
Go ahead, Rashmi. Go ahead.
So what is your question actually, Kinfon? What did you ask?
Yeah, I mean, do you observe that there are two subsets of GPPs? The first subset are those having only one flare or two flares a year, but they are well in between. There's another subset that have a progressive disease.
Yeah, we do see it. I have never thought of it actually as two subsets, but when you say that, you're right, that there are people, exactly falling into these two categories.
Yeah.
Do you do the IL-36RN and CAT14 mutations for all your patients with either the pustular psoriasis type of phenotype or the CAT14 type of phenotype?
We mainly are doing those early onset because we do have limited resources to do it. Those early onset without plaque has an outside of the disease. Yeah, then we go for IL-36RN or CAT14. Yeah.
That's very interesting. We don't do it routinely as well unless they really don't respond so well. But so far, I think most of our patients are able to be controlled with either cyclosporine, acitretin, or methotrexate. Yeah. But interesting case. Yeah.
There are a few questions, which maybe you could take up, I'll just ask these questions. Dr. Shinoy has asked, role of biologics in PRP. I think, Kinfon, you had mentioned about it in PRP, which was quite interesting. And in fact, that was my question also. So which one would you prefer out of the whole lot?
Yeah. If we are talking about the classical PRP in children, usually they do improve over time. So this subset, I probably just symptomatically control, make sure that the palmar-plantar keratoderma does not disturb their fine motor functions. The itchiness does not really disturb their quality of life. Those subset of patients, I just give them acitretin or MTX. But there's another subset that has put up earlier in my lectures that the patient have very early onset with CAT40 mutation, especially if then that tends to have the atypical presentations, and this might benefit from biologics. You compare biologics, acitretin and cyclosporine on long term, I would still say the either acitretin or biologics is our options. Mark, what do you think?
Totally agree. Totally agree. Yeah. I mean, the good thing is most of our PRPs are mild and just very limited, and even topicals will control them. And once in a while, you get one of these more severe ones that really don't respond to much other things, and then you have to go on to the biologics.
Yeah.
So I think we have another question from Dr. Deepti Desai. Use of spesolimab.
The Speso is IL-36 inhibitor. It's not approved yet in children, but my colleagues in center that using under the trial with spesolimab, they say is in fact is even more effective than IL-17 in terms of inducing remissions. But the safety profile, I think definitely we need more long-term study to prove it. And for the time being, obviously I would go for IL-17 because the safety profile, at least a couple of years already, then is more reassuring than using something new. How about Dr. Henrietta? What do you think? What is your opinion?
Yes, similar. because that's still in the Spisolimab is still not approved yet. So I would use secukinumab as well, seeing how it is effective it was for patients.
Yeah.
There's just one more question from Dr. Sudhir Pujara. Dr. Leong, please share your view on using calcipotriol ointment and 10% benzoyl peroxide for prurigo nodularis. You use that?
Yeah, personally, first of all, I have not used them. Secondly, I think the main challenge is that whatever you apply, sometimes the penetration cannot go deep enough. I think if you find it helpful, also probably just an adjunct and can't replace the something from systemic or very potent, ultra potent topical corticosteroid wet wrap. I think one of our challenges is the penetration of the medication if you apply over the skin. I don't know whether the other panelists have used this calcipotriol and PP or not.
No, I've not used for prurigo nodularis. I've tried Colta, and I find sometimes quite good results. Colta for some of these thicker lesions, especially like LSC, in addition to the so potent topical steroids. Yeah. Okay, I think we have one more presentation for this segment. Do you think we should move on to that one?
Yeah, oh, before we take the rest?
Yeah, yes, there's a fourth one. Then. Yes, yeah. Yes. Okay, so
I thought we're done actually.
No, we've got one more. Yeah. Right. And this is
that's why I was giving a feast of questions, you know.
Okay, Dr. Kathleen.
Hi, can you see my slide?
Yes. Okay, you have to put in slideshow, yeah.
Okay. So good evening. I will discuss on the use of biologics in autosomal recessive congenital ichthyosis in pediatric patients. Our patient is a 14-year-old male who was born full-term to non-consanguineous parents. At birth, he was noted to be encased in a collodion membrane, which later shed to reveal generalized large plate-like, centrally adherent brown scales, more prominent over the scalp and upper and lower extremities. Ectropion and mild erythema beneath the scaling were noted. His parents and two older siblings were unaffected, and genetic testing done revealed a heterozygous transglutaminase 1 mutation. For the first question, presented with these findings, what is the patient's likely diagnosis? Okay, so the findings of collodion membrane at birth, which later shed to form generalized large plate-like brown scales and transglutaminase 1 mutation, points to a diagnosis of lamellar ichthyosis. For the next question, aside from liberal application of topical keratolytic and emollient, what else would be the most appropriate management to initiate for our patient? Is it A, topical corticosteroid, B, phototherapy, C, a systemic immunosuppressant, or D, systemic retinoid? Okay, so treatment for ichthyosis is largely supportive. For more severe cases, systemic retinoids are often initiated to improve the hyperkeratosis. The patient was maintained on acitretin and 10% urea for several years. He was also on cholecalciferol supplementation due to an underlying vitamin D deficiency. A year ago, he was started on off-label use of secukinumab, given subcutaneously once weekly for the first 5 weeks, then monthly thereafter for the maintenance dose. As was discussed earlier, some ichthyosis subtypes have increased interleukin-17 levels similar to the immune dysregulation found in psoriasis. As such, it has been proposed that biologics and inhibitors intended for use in psoriasis might be a promising strategy for treating ichthyosis. These photos show the patient after a year of using secukinumab. Ectropion, scaling, and minimal erythema were still persistent, although of much less severity. Currently, he is maintained on monthly secukinumab injections and a lower dose of acitretin. Secukinumab is FDA approved for use in children aged 6 above and adults with moderate to severe plaque psoriasis, and psoriatic arthritis. Its use in ichthyosis, however, is currently off-label. In the pediatric population, published cases are limited to a few case reports. So I found this article which reports of the use of secukinumab in an 8-year-old male with severe erythrodermic ARCI. The patient received secukinumab for 6 months together with topical emollient and mild keratolytic. He was reported to have striking improvement in erythemine scaling as early as 4 weeks of use. Occasionally, and towards the end of the 6-month therapeutic period, the frequency of bathing and extent of topical treatment were reduced. Treatment was well tolerated and there was no mention of increased or opportunistic infections. For the discussion, can our panel kindly share their experiences with the use of biologics for pediatric ichthyosis? Thank you.
Thanks, Dr. Kathleen. So this case was from Singapore. Kin Fong, your experience, I think go ahead.
I would look at the erythema to decide. And this case, you can see carefully they do have a erythema background. So maybe it's somewhere around intermediate between the non-bullous ectasiform erythroderma and laminar ichthyosis. In fact, we have tried one on a so-called classical laminar ichthyosis. Unfortunately, the skills does not improve much, and the mother also give less than 20% improvement. So that particular case, we didn't continue with secukinumab. And the other two cases and another Netherton syndrome have a very prominent erythema, has a background of the disease. So far in my center, we only prescribe for those after shared discussion, only those with prominent erythema and not those just pure thickness scales.
Yeah, that's a great tip, Kin Fong. For Nethertons, I think there's been use of both the IL-17s as well as the dupilumab as well. So, I mean, it'd be great if we could do the cytokine profile for these patients and we know which one to block.
And I have a gut feeling that it's a progressive changes. Means, let's say I look at my Netherton syndrome babies, most of them have very prominent redness, but over time the skills start to build up over time. So I believe it's just like atopic eczema, acute, subacute, and chronic. They do have some changes in the cytokine profiles. And can you do it? If you can do it, I can send to you.
We are trying out some new ways of trying to do it, but I think that's the future of how we're going to go. I mean, like some of these dupilumab resistant patients, right, or they get worse. I don't know. I mean, maybe they have more of a Th1 profile than a Th2 in these eczema patients. But I guess, for ichthyosis, if they do respond, treatment will be almost for life. So we have to be a little bit careful about the long-term side effects as well. I think there are just a couple of questions on, I think maybe we should just take the questions on the JAK inhibitors.
I think quickly, maybe there are just few. So there are...
maybe we just take the ones on the JAK inhibitors, because I think
only
that's
some
something...
we can take. I think this we can take that, quickly. How common is underlying renal disease in patients of prurigo nodularis?
We don't see that.
Marco did say that he doesn't see many, and neither have I seen many actually. So
I think they're dealing with pediatrics, so it's slightly different.
Correct.
The comorbidity.
Thalidomide, I've never used it for prurigo nodularis.
Then Dr. Sujushe has asked the total cost of dupilumab for complete course for treating prurigo nodularis. How to counsel parents in prurigo nodularis?
We just tell them it's expensive. A lot of our patients get paid by insurance. Those that don't have, we do get some medical funding for them. So I think different countries will have different prices as well.
True.
And well, I mean, I do tell patients that usually I'll give for a year at least if there's good response, and then from there, if the response is pretty good, then I'll try to slowly cut down from there. But some patients are on once every, sometimes 6 weeks, 2 months. I even have a patient who does it once every 3 months. But sometimes these costs, if you translate it to quality of life, it's incredible. Yeah.
So the advantage is you don't need to go for regular blood taking, and of course, just a single jab every 2 to 4 weeks based on the age of the patients.
I think the JAK inhibitors, maybe I'll take on that. We've been involved with the JAK studies as well. I find so the one that with the one that we've been on is upadacitinib, but abrocitinib, and I think there's one more baricitinib that's been approved. So we find that the JAK tends to have faster response. The response is, I find the response also a little bit more solid than the biologics dupilumab. So a lot of them get at least EASI-90, and they get it pretty quickly within sometimes, just a couple of months, they're EASI-90 already. However, when stopping it, they come back pretty quickly. And of course, I think the side effect profile is not as good as the dupilumab. Kim Fong, have you tried the JAKs?
I have only one adolescent patient, and you have highlighted that the onset is faster, but the side effect profiles is a bit guarded compared to dupilumab. Yeah, of course, the advantage, no need to go for injection. We do agree that the dupilumab subcutaneous injection is indeed painful. It's a 2 cc of so medication goes subcutaneous. It did create a little lumps for a couple of hours.
Yeah. So that's one advantage. That's oral therapy. Price is about the same.
Yeah.
I think when you calculate it by month.
Yeah.
Okay. I think, shall we move on to our second topic? I think we're a little pressed for time.
I think we should move on, because if we have time, we'll come back again.
Okay,
There's
so
a lot of interest.
Okay, so we're back to Dr. Surabi.
Thank you. Before that, I just have 2 things to say. Somebody asked that how do you want to join the membership? Yes, you can log on to www.asianpedderm.com. So that is pederm with 2 Ds, PED and derm. I've shown you in my slides. So that is one way that you can become a member. And the second thing is, we are very great. Also, I should like to thank Ajanta Pharma, because they are our academic partners, for hosting these webinars here, right? So over to you, Surabhi.
Thank you, ma'am. Thank you, Dr. Kinfon, Dr. Mark, and all the presenters for such lively and informative sessions. Good to know about such encouraging results, though in India, we are yet to get to work with dupilumab actually. So we quickly move on to our next hot topic, which is updates in the diagnosis and management on infantile hemangiomas. And to deliver which, we have Dr. Mark Ko. He's the Honorary Secretary of the ASPD, also an internationally acclaimed authority on the topic. And he's a consultant in the Department of Dermatology at the KK Hospital, Singapore. Following his recorded talk, we shall have case presentations again on the same broad topic. Dr. Wilcy Salas Valensundan works in the East Avenue Medical Center, Philippines. She will be presenting a case. Then Dr. Lynette Wei Yi is a consultant in the Department of Dermatology at KK Hospital, Singapore. And lastly, Dr. Julie Raharja is a member of the Indonesian Pediatric Dermatology Study Group, and she shall also be presenting a case. And we again would request all delegates to please keep posting your questions on the chat box. We shall try to take as many as possible. And please keep responding to the poll quizzes as well. So Bharat, could you please put on the lecture of Dr. Marko, please?
Yes.
Good evening, everyone. I'll be speaking now on infantile hemangiomas, and we'll be giving updates on the diagnosis and management. I'm Dr. Mark Koh from KK Women's and Children's Hospital in Singapore. These are my disclosures, and none pertains to this talk. As we know, infantile hemangiomas are probably the commonest benign soft tissue tumor of childhood and affects up to 4% of newborns. The older terms that we used to use, such as strawberry or cavernous or capillary hemangiomas, have now been replaced by the term infantile hemangiomas. So that clinical history is very, very important. All hemangiomas follow a very classical growth pattern. It's usually not there at birth. It grows fast in the first 5 to 6 months of life. This growth then slows down over the next 5 to 6 months. And after that, at about 1 year of age, it starts to involute, and it will take several years for final involution. Infantile hemangiomas can present in various ways. Commonest is the superficial hemangioma, where it presents as a very soft reddish nodule. Deep hemangiomas present as, again, soft, slightly bluish nodules, and these sometimes can be mistaken for other conditions such as dermoid cysts and lipomas. Mixed hemangiomas are also very common, and they have both the deep component as well as a superficial component. It's important that these lesions are always soft and squishy. If something is hard, it's probably not an infantile hemangioma. They are warm to touch because they are made up of blood vessels. In cases where you're not sure of the diagnosis, we like to use the Doppler, and this is a handheld Doppler that we have in our clinic, and you can hear a whoosh emanating from these hemangiomas. So that's a very classical whoosh that you hear for infantile hemangiomas. There are some tricky cases that sometimes we are foxed. This is a case that presented with what looks like a port wine stain at birth. However, at 2 months, you can see that this lesion has progressed, it has become thicker, and has gone beyond its initial boundary. This was another tricky case that came to us at 1 month of life with what appears to be a port wine stain on the left side of the face, nose, as well as philtrum, but you can see there is some ulceration seen at the upper lip. So we asked the mom for pictures at birth, and you can see that it has also progressed over the 1 month. In terms of pathology, we hardly ever see infantile hemangiomas, but if we do, what you'll see are intradermal or subcutaneous proliferations of small vascular spaces lined by these very plump endothelial cells. In the early stages, vessels are very slit-like and very compact. With maturation, the vessels enlarge and dilate. Finally, in the later stages, the vessels get replaced by this fibrofatty tissue. A very important immunostain is the GLUT1 stain. Infantile hemangiomas express GLUT1, which is an erythrocyte-type glucose transporter protein. And importantly, GLUT1 is not expressed in other vascular tumors in children, so it's very useful to differentiate infantile hemangiomas from other vascular tumors and malformations using the GLUT1 stain. Also important is to identify syndromes that are associated with larger hemangiomas, and the most well-known of this is the FACES syndrome. So FACES stands for posterior fossa abnormalities, commonest of which is the Danny Walker or cerebellar hypoplasia or dysgenesis. H stands for hemangioma, which is segmental and it can be found on the head and neck region, sometimes on the upper limb or the upper trunk. A stands for arterial abnormalities, for which can be intra or extracranial. C stands for cardiac defects, most commonly or most classically aortic coarctation. E stands for eye abnormalities, and S for sternal cleft and supraumbilical raphe. So you can see these two pictures here of patients with FACES syndrome. You can see a large segmental hemangioma affecting the face, and if more segments are affected, or if higher segments are affected, the risk of FACES syndrome has been found to be more common. So what are the investigations that we do if we suspect FACES syndrome? We will send them to the echo to look for cardiac abnormalities. All patients will also get an MRI and MRA of the head and neck region to look for any brain abnormalities or arterial abnormalities in the head and neck region. And we also refer them to pediatric ophthalmologist. Another hemangioma to look out for is the beard hemangioma. And this is a large segmental hemangioma that affects the mandibular region. And why it is dangerous is because they can get airway involvement. So we always refer these patients to the ENT surgeon for a scope to look to see if there is involvement of the airway. And also important is to exclude faces in these patients. So they have to undergo to the echo, MRI, MRA, as well as an eye consultation. Another well-known syndrome is the lumbar, pelvis, or sacral syndrome. I tend to use pelvis more commonly. So what it stands for is P for a large perineal segmental hemangioma. E stands for external genital malformation. L, lipomyelomenincocele. V, vesicorenal abnormalities. I, imperfect anus, and X, S for skin tag. So you can see this patient has a large segmental hemangioma in the lumbosacral region and around the anal region as well. You can see a large dimple here as well, and this points to a possible abnormality in the spine. These are other pictures of patients with the pelvis syndrome, you can see again segmental hemangiomas over the groin region and the perianal region. So all patients will have to undergo an MRI of the lumbosacral spine to look for spinal abnormalities. And if these are found, we refer them to the neurosurgeon for further management. We also order either an ultrasound or MRI of the genital urinary system. Some of our babies have multiple hemangiomas. This is not common, but if you find babies with more than 5 discrete hemangiomas, we have to look out for visceral involvement, especially liver involvement. So we send them for ultrasound or CT of the abdomen. And if we do find visceral hemangioma, we will do a thyroid function test because they can get hypothyroidism, and this is due to production of type 3 iodothyronin deiodinase, which deactivates the thyroid hormones. Some of the differential diagnosis of infantile hemangiomas. This is a baby that was born with a hemangioma that was fully formed at birth and undergoes some amount of evolution over the next few months. This is a congenital hemangioma, or also known as RICH, which stands for rapidly involuting congenital hemangioma. So these hemangiomas are almost fully formed or fully formed at birth, and most of them undergo regression over the next few months or the next few years. And this is a classical diagram of the growth of the congenital hemangioma, where it grows in utero and at birth is almost fully formed. And some of them do undergo evolution over the first year, some of them do not, in which case we call them a niche. And this is compared to the growth pattern of a regular infantile hemangioma, which is usually not present at birth and gets bigger in the first year of life and then evolves. And these are pictures of congenital hemangiomas at birth. You can see that sometimes they have this peripheral halo surrounding an area with telangiectasias. This is another differential diagnosis, a rare condition where you get this vivacious plug over the limb or the trunk. A newborn or in the first few weeks of life, and sometimes it becomes very hard, and patients may get low platelets as well as clotting abnormalities. This is Kaposiform hemangioendothelioma, which is a locally aggressive vascular tumor which presents as a firm subcutaneous nodule or plug that can rapidly expand and has more of a vivacious discoloration as compared to a hemangioma. It usually occurs in infancy, but may appear sometimes months to years later. It can involve the deep tissues in the bone and may be associated with the Cassavant-Merritt phenomenon. This is a very common differential that sometimes presents to the clinic. It can be a young child, it can be an older child, and sometimes even infants. And this is a pyogenic granuloma, which grows over a few weeks or sometimes a few months. It's common, it can occur at any age, grows faster than infantile hemangioma, it often bleeds, especially on trauma, and these do not tend to involute spontaneously, and sometimes they present to the clinic and we have to do a shave biopsy. This is a less common differential diagnosis. This presents usually in the first few months of life with a soft bluish swelling. This is a lymphatic malformation. It's fairly uncommon. They can appear at birth, but sometimes they become more obvious only in infancy or early childhood. There's usually no growth phase and grows with the child. Infections and pain can occur, and when you use a Doppler, there is no whoosh that you hear. Some complications of infantile hemangiomas, it can lead to impairment of function. For example, those around the eye region can lead to eye complications such as astigmatism, visual axis obstruction, and strabismus. Those around the mouth and the lip area can lead to feeding difficulties, especially if there's ulceration. And of course, we talked about those in the beard distribution, where there's a risk for upper airway or subglottic infantile hemangiomas. And those in the perianal region can lead to damaged anal sphincter or incontinence. Those on the liver can cause cardiac failure, hypothyroidism, or hemorrhage. Ulceration is one of the more common complications of infantile hemangiomas and can affect up to 15% of infantile hemangiomas. And it's more common in larger segmental infantile hemangiomas, as well as those located in certain sites such as the groin region, the neck region, the axilla, and behind the ears. It can lead to pain, infection, bleeding, as well as scarring. Finally, infantile hemangiomas can lead to disfigurement, even though we know that infantile hemangiomas involute over a few years. It can lead to permanent scarring and disfigurement, especially if they are large, or especially if they have ulcerated. They can distort the normal anatomy, lead to fibrofatty change, some atrophy of the skin, scarring, dyspigmentation, and residual telangiectasias. So then, how do we treat infantile hemangiomas? In the past, we used to have quite a lot of different treatments, which worked most of the time, but had quite high side effect profile. Of course, over the last 10 years, many of us have used beta blockers, in particular oral propranolol or topical timolol. So propranolol was first discovered to be useful in the treatment of infantile hemangiomas about a decade ago by a group led by Christine Lebrace in France. Since then, a lot of us have treated lots of hemangiomas with propranolol. In terms of the mechanisms of action, there are a few that have been postulated. Initially, there's a local hemodynamic effect, and as you can see in a lot of patients, once you start the propranolol, the lesion starts to get smaller over a few days. However, this effect is usually not long lasting, and that's why we treat for quite a few months. Subsequently, there's an anti-angiogenic effect, and finally, propranolol also can lead to apoptosis of the capillary endothelial cells. It's a pretty safe medication. Common side effects include sleep disturbance, or sometimes some babies may sleep a little bit more. They can also get cool extremities. Rarely, there's a theoretical risk of asymptomatic hypotension or bradycardia. We've seen some patients, rarely, with pulmonary symptoms such as wheezing, especially in premature babies with chronic lung disease. Rarely, we've seen symptomatic hypotension or bradycardia have also been reported, and hypoglycemia is also reportedly rare. So these are some of the pictures of treatment of our patients with propranolol. As you can see here, after a few months of treatment, you can see almost 90% improvement. There's a child with ulcerated ear hemangioma. Again, after 6 months of treatment, almost 80% involution. This was a child with faces syndrome. After 4 months of treatment, you can see that the upper eyelid is much smaller now, and the eye apertures are almost equal. This is the baby with pelvis syndrome. You can see after a year of treatment, most of the hemangioma has involuted. There's a scar here from surgery to the spine. It does work for ulceration as well, so it can heal up ulceration quite fast over a few weeks. This is a ulcerated hemangioma over the groin region, and you can see after 4 to 5 months of treatment, the ulceration is healed and the hemangioma is much smaller now. So what have we learned from treatment of infantile hemangiomas with propranolol? Earlier the treatment, before 6 months, you get better results. Sometimes we treat after 6 months, but less than a year, you still get pretty good results. After a year, the results are usually not as good. So we do ask for early referrals for patients with complicated infantile hemangiomas that will require treatment with propranolol. The optimal dose we find, and in most papers, is between 2 to 3 milligrams per kilogram per day, and 2 or 3 divided doses. Usually, if you had to go beyond 3 milligrams per kilogram per day, the effect is not much more. Duration of treatment, we usually treat till about 1 year of age, or at least 6 months of treatment. There is a small percentage which have poor response, and a small percentage with recurrence. In terms of monitoring, for our patient monitoring, we usually do a baseline heart rate, blood pressure, and ECG, and we monitor with a blood pressure and heart rate hourly for 2 hours before patients are discharged. Inpatient monitoring, we hardly do that now, but sometimes we do admit them if there are comorbidities or very young units, less than 6 weeks of age. So there are some issues with treatment with propranolol. Of course, one of the issues is the use of oral propranolol in patients with faces syndrome. This is a very recent study that's published. It's a multi-center retrospective cohort study looking at 76 patients with faces syndrome. Oral propranolol was given at about 0.3 milligrams per kilogram per dose. there were no reports of serious adverse events. 46 non-serious adverse events were reported in 38% of patients, particular sleep disturbance, some minor GI tract and respiratory tract symptoms. However, there's no significant difference in serious adverse events when compared to a group of infants on oral propranolol for infantile hemangioma, but no faces syndrome. So generally, it's shown to be very safe in patients with faces syndrome. In our own practice, we generally tend to not give we tend to increase the dose slowly in faces syndrome, and we usually stop at about 2.5 milligrams per kilogram per day. What about propranolol resistant infantile hemangiomas? This was a study in 2013 looking at was a national multi-center retrospective observational study. They found that these patients had continued growth during the proliferative stage or no decrease during the post-proliferative stage after at least 4 weeks of oral propranolol at least 2 milligrams per kilogram per day. So they found that of 1,130 patients, 10 patients had propranolol resistant infantile hemangiomas, which works out to be about 1% of babies. And these babies, sometimes we do add on other treatments such as with oral steroids or topical timolol or with lasers. What about the recurrence rate of infantile hemangiomas after oral propranolol therapy? This was a recent study as well, a retrospective analysis looking at 198 cases. They found that there was regrowth after oral propranolol therapy was stopped in about 35 of these patients, which works out to be about 18% of babies treated with oral propranolol. And facial hemangiomas showed a higher relapse rate compared with the other sites. Of the 35 relapse cases, 66% underwent a second cycle of propranolol with successful outcome. What about the use of other beta blockers? This was a study comparing propranolol with atenolol in infants with problematic infantile hemangiomas. It was a prospective, multi-center, randomized, controlled, open-label clinical trial. They had 377 patients randomized to either propranolol or atenolol groups. After 6 months of treatment, the overall response rate was almost equal between the two groups. Both groups had similar, complete or nearly complete response in 2 years. The adverse events was more common in the propranolol group, but severe adverse events did not differ between the groups. So the conclusion was that atenolol, which can be given once a day, can be used as an alternative option for patients with infantile hemangiomas who require systemic therapy. Another beta blocker that has been described is nadolol. So this was a study comparing nadolol with propranolol in infants with IH. It was a double-blind, non-inferiority prospective study in infants 1 to 6 months with problematic infantile hemangiomas. They were given either oral propranolol or oral nadolol at escalating doses up to 2 milligrams per kilogram per day. They had 71 patients, equal in both groups. The difference in infantile hemangioma between the groups was 8.8 for size and 17.1 for color in favor of the nadolol group, demonstrating that nadolol was non-inferior to propranolol. So the conclusion was that oral nadolol was non-inferior to oral propranolol, indicating that it may be an efficacious and safe alternative in cases of propranolol unresponsive patients or those with adverse events with propranolol or when faster involution is required. What about the use of topical beta blockers? So the one that we've used over the last number of years is topical timolol. This is the preparation that we use. This was the first paper that described the use of topical timolol by Elena Pope in Canada. These are some pictures of our patients that were treated with topical timolol. So generally, we find that the more superficial hemangiomas tend to respond better. It takes some time, it took 10 months. Sometimes it stops the growth of the hemangioma. Sometimes the evolution is not complete. And in some patients, rarely, sometimes it may not work. So what have we learned from topical timolol? We tend to get better outcomes in thinner lesions or when we start treatment early. We treat for at least 6 months or until 1 year of age. So far, no major adverse complications, so there's not much need for monitoring. So we do recommend these in patients which have non-critical infantile hemangiomas, those that are non-life or non-function threatening, or sometimes in patients whose parents are not comfortable with treatment with systemic beta blockers. What about the use of lasers for infantile hemangiomas? Some of the indications for the use of pulse dye laser in infantile hemangiomas are hemangiomas that are in the early macular stages. It can work quite well. Ulcerated hemangiomas also respond to lasers, or those with residual telangiectasias or atrophy. There's some studies to show that the Nd:YAG laser at 1064 nanometers may be useful for the thicker, larger infantile hemangiomas as they do penetrate the skin a little bit deeper. And now some groups have started combining the pulse dye laser with the Nd:YAG laser, and these have shown promising results as well. This was a patient that we had treated, came in with a very large ulcerated hemangioma on the left cheek. We gave propranolol and prednisolone, the ulcer healed up, and the hemangioma was smaller, but we added on pulse dye laser. As you can see, most of the hemangioma has settled down, leaving just some telangiectasias and some scarring from the initial ulceration. So in conclusion, infantile hemangiomas are very common. Most do not require treatment. However, those that are more complicated require early treatment with beta blockers, and they have shown very good results. Both oral propranolol and topical timolol are useful in the appropriate lesions. We can use lasers as well, may be attempted for proliferating early infantile hemangiomas or for the treatment of sequelae of infantile hemangiomas. Also, always remember to think of the syndromes that are associated with infantile hemangiomas and to investigate for them if required. And with that, I want to thank you for your kind attention.
So thank you so much, Mark, for that case, for that lecture. And I think we'll directly go over to the cases now. And after that, we can do the discussion in the end, right? We'll take up the questions. Over to you, Surbhi.
Okay, I think we have the first presentation by
Wills.
Dr. Wilsey.
Yes, she's there.
Yes.
Thank you very much. Good evening, everyone. I'm humbled to be invited today to share with you some ulcerated hemangioma cases I've managed in my practice so far. I'm Dr. Wilsey Salas Walinsandin. I'm an assistant professor and a consultant pediatric dermatologist from the Philippines. So we start off with a case of a 2-month-old boy born 29 weeks age of gestation via normal spontaneous delivery to a 31-year-old Gravida 2 Para 2 with no fetal-maternal complications. The patient was brought for consult due to an ulcerated mass on the lower lip. At birth, the patient presented with a small dark blue-red macule on the lower lip, and at 2 months, there was no enlargement of the plaque and ulceration associated with scaling, dryness, and occasional bleeding, wherein the patient was noted to have difficulty in feeding. The patient was then brought for consult to me, and I advised vascular ultrasound, and it revealed hemangioma. So here we see a well-defined ulcerating hemangioma measuring 1.5 by 2 by 0.5 centimeter over the lower lip. So I managed the patient with propranolol. I started the doses at 1.5 milligram per kilogram per dose, but I had to subdivide the doses into 3 or give it every 8 hours because the patient's heart rate usually slows down. So the second case is a case of a 7-month-old baby girl who was referred because of an ulcerating plaque on the sacral area. Patient was born term via spontaneous delivery to a 30-year-old Gravida 2 Para 2 with no fetal-maternal complication. And the erythematous plaque was actually absent at birth and just appeared at the 2nd week of life. The lesion grew out of proportion to the growth of the patient until 5 months prior. The lesion presented with the central ulceration and associated pain, discomfort, and irritability upon urination, defecation, and diaper changes. There were no episodes of loose watery stools and no history of trauma, no family history of vascular tumors or malformation. So here we see several well-defined ulcerated hemangioma plaque measuring 4.5 by 3.2 by 0.5 centimeter over the intergluteal cleft. So for this patient, I treated with propranolol. I started at 1 milligram per kilogram per dose, slowly escalated until I reached 3 milligram per kilogram per day. I also mixed this patient with corticosteroid, oral corticosteroid at 0.5 milligram per kilogram per dose. This just shows the diascopy, which shows a non-blanching plaque over the gluteal area. So for the polling questions, I would like to ask everyone, how common is ulcerated hemangioma in your practice? Is it letter A, greater than 20%, letter B, 10 to 20%, letter C, less than 10%, letter D, less than 5%, or letter E, I have never seen any? So I'll give you 10 seconds to answer the poll. And we shall close the poll in 5, 4, 3, 2, 1.
So trying to wait for the answer which Bharat, actually he sent you already. Yeah.
Yeah, so 100% has never seen infantile hemangioma in their practice. So for me, since I work at the referral center, I usually see hemangioma, and ulcerated hemangioma is usually around greater than 20% of the cases I see. Okay, on for the next poll question. What will you do if you see an ulcerated hemangioma on the face or sacral area? So letter A, attempt treatment. Letter B, refer to a specialized center. Letter C, do imaging before attempting treatment. Or letter D, unsure of what to do. So again, I'll give you 10 seconds to key in your answers. Okay, we'll close the poll in 5, 4, 3, 2, and 1. Can we pull up the poll? All right, so the poll says that half of the viewers will say they'll do imaging before treating, and then 25% will say they'll attempt treatment, and 25% will just refer to a specialized center. So this actually is the infantile hemangioma referral score. So this was developed by pediatricians, dermatologists, vascular surgeons. And this just goes to show that if there is you just have to tick one. And if you tick one, it means you need to refer your patient to an expert center, vascular center, or anyone who has the capability to treat hemangioma. So for our 2 patients, they had the complication or potential for ulceration. You tick one, so it's good to refer the patient to a specialized center. And then lastly, true or false, ulcerated hemangioma can be managed by intelligent neglect or watchful waiting. Letter A, true. Letter B, false. Letter C, unsure of the answer. 10 seconds. Okay, last 5, 4, 3, 2, 1. Do we have answers to the poll? Of course, if it's already an ulcerated hemangioma, you should not manage it by watchful waiting or intelligent neglect. So here are my questions to the panelists. Is there a role for specialized wound dressing for ulcerated hemangioma, especially in the mucous membranes or sacral area? And aside from corticosteroids and beta blockers, what are other treatment options for ulcerated hemangioma? Thank you.
Thank you, Dr. Wilsey. I think in the interest of time, we're really running out of time. We will present all the cases. So can we have our second presenter, Dr. Lynette?
Hi, good evening. I'm Dr. Lynette Wee. Okay, when is infantile hemangioma more than just skin deep? All right, so I'll start with the first case. This is a 15-year-old girl who presents with a segmental erythematous patch over the left side of her face, as well as her nose, her philtrum, and her lip since 1 week old. It then progressed in size and color intensity. She was admitted for ulceration of her upper lip lesion. And this is the photo of the time she was admitted. So poll question, you can start the poll. What further investigations will you do for this child? A, ultrasound and Doppler of the lesion as well as brain and refers to eye. B, MRI brain and refer to eye and ENT. C, MRA brain, orbit, neck, refer to eye and 2D echocardiogram. D, ultrasound and Doppler of lesion and refer to ENT. And E, no need further evaluation as this is benign. Okay, we'll close the poll in 3, 2, 1. Okay, let me wait for the poll results.
Yeah, I think we'll just put up the poll results.
Okay, it's okay. While waiting for it, I'll just move on first. I'll come back to this later. So she was worked up for faces syndrome, okay, with MRI.
I think we have the question answers.
Yep, that's right. She was worked up for faces syndrome with MRI, MRA brain, and her carotids, had a 2D echocardiogram and an eye examination. And that is the answer. So C is the answer. So excellent. I think Dr. Mark gave an excellent lecture. So we have 100% of our participants answering this question correctly. So for this child, 2D echo showed a small atrial septal defect and eye examination showed bilateral high hyperopia with partially accommodative esotropia, and she was given glasses. So MRA brain showed dysplastic and hypoplastic left cerebellar hemisphere with a focus of heterotopia on the left, frontal periventricular white matter over here, and this is cerebellar hyperplasia. She also had a hypoplastic right internal carotid artery, and both the anterior cerebral artery was supplied by the left internal carotid artery. Okay, this is the second poll question. You can start the poll rolling. What is the best management option for this patient? Is it A, propranolol, B, prednisolone, C, pulse dye laser, and subsequent residual for the ulcer currently, and later on, a couple of years, for the subsequent residual erythema and telangiectasia, D, ulcer care, or all of the above? Okay, we'll close the poll in 5, 4, 3, 2, 1. Okay, we do not have the poll results. I'm waiting for it, but the answer is, of course, all of the above. I'm sure it's 100%. So further case progression. So her ulcer was treated with systemic antibiotics and wound care, and she was started on propranolol, as well as a short course of prednisolone. Subsequently, she was maintained on timolol topical. Newer developmentally, she has isolated mouth, speech, and language delay, and she's on early intervention program. Neurology is normal, except for deep tendon reflexes being more brisk in her left lower limb compared to the right side. So we all know that this is faces syndrome. It's a rare neurocutaneous syndrome. A bit of the pathophysiology. It has been postulated that face-associated structural abnormalities can be attributed to regional ischemia from adjacent arterial anomalies. That also results in structural abnormalities that are commonly ipsilateral to the arteriopathies and or the facial hemangioma. Although a single causative gene has not yet emerged, rare variants in matricellular signaling genes have been identified. So RNF213 in Moyamoya disease have been identified before. So genetic variants may be useful biomarkers to predict which individuals with face are more likely to experience neurovascular complications, and this will be important for long-term prognosticating factors as well as the frequency of follow-up and neuroimaging. So this is just a quick summary that I've tried to put together that Dr. Ma has very clearly gone through. Faces, posterior fossa malformation, the hemangioma of the cervical facial region. So those large hemangiomas that segmental 5 centimeters or more, whether that's deep or superficial component, that especially affects S1, 3, and 4 and the scalp are at higher risk. Arterial, cardiac, eye, and sternal abnormalities. So this is a photo of a sternal and abdominal raphe that some of you may not have seen before. So there are other systemic complications, okay, that's been described before. So particularly endocrine that can be related to hypothyroidism or hypopituitarism, growth hormone deficiency, as well as central adrenal insufficiency, especially if there's midline defect. Headaches is quite commonly reported in as young as 4 or 5-year-old toddlers. That is migraine-like and can be quite debilitating, that requires treatment. Many of the faces syndrome children have hearing loss, as well as neurodevelopmental delay in the motor, most commonly followed by language and then cognitive impairment. They may have dental issues like enamel or dental root problems, as well as multiple cavities that would require early dental checks and evaluation. So 2 points for panel discussion would be how would the initiation and dose titration of propranolol be different in a child with phases compared to one with just a simple infantile hemangioma? As well as the second one, given the possibility of vasculopathy progression and stroke, what frequency and duration of observation and clinical review do you recommend in children with phases syndrome? Thank you for your attention.
Thank you, Dr. Nanette. Shall we have the last case by Dr. Julie?
Yes, please.
Please go ahead, Dr. Julie.
Can you see my slide?
Yes, we can see.
Hello, everyone. It's a pleasure to be here. I'm Julie. We'll present the infantile hemangioma recalcitrant to treatment. Oh, I cannot go through.
Please click on the screen.
Me?
Please click on the screen, doctor.
Already, but cannot.
Do you see arrow mark? Yeah.
Okay, our first case was a 1-month-old girl presented with large segmental erythematous patch over the left side of her face, eyelids, and temporal area of the head that noticed since birth. In USG Doppler, we sent hypervascular lesions, and because of the specific distribution, we still consider as phase syndrome. We like to ask everyone to vote again. What is the first line therapy for this child? Surgical excisions, propranolol oral, topical timolol, pulse-day lasers, or topical steroid. We gave you 20 seconds. Okay. Okay, seems like everyone choose, sorry. This is one. Oh, okay, the topical steroid. The propranolol. It seems like everyone choose a propranolol oral. That's great. Okay, although most infantile hemangioma can resolve spontaneously, there are some cases that need prompt treatment, such as ulcerations, life-threatening complications, functional impairment, or physical disfigurement. He given propranolol oral with initial dose of 1 milligram kg per day, twice daily, then increased double dose, but still no fail. Okay, then our second case, a healthy 5-month-old boy presented with raised red vascular lesions on right temporal area that had been noticed a few weeks after birth that progressed in size. Dermatoscopy reveals red round oval structure resembling lacunae with white septate. Likewise, he was also given propranolol oral at initial dose 1 milligram body weight per day, increased 2-3 milligrams per day, combined with topical timolol, but still no response. For second questions, what do you think that are the possible causes of propranolol recalcitrance in infantile hemangioma? Anatomic locations, resistant to beta blockers, suboptimal dosage, poor compliance, or all of the above. We give you 20 seconds. We close the pool in 5, 4, 3, 2, 1. Okay, great, excellent. Seems like everyone choose all of the above. Yep. Okay, the non-responsiveness to propranolol can be attributed to absence or reduced in beta receptors, resistant to beta blockers, anatomic locations such as in the beard area or paraglottic gland, and ulcerations, infantile hemangioma, poor compliance by the parents or non-adherence to treatment. And the recent study showed that MIR-187-3P, a novel tumor-related microRNA, is lower in non-responsiveness to propranolol. This is my point for panel discussions. When we can determine the propranolol is working or not, do we need to give combination therapy in the case of recalcitrant to propranolol, or do we need to alternate the treatment? Thank you for your attention.
Thank you, Dr. Julie. Again, 3 very interesting types of cases. for hemangiomas. Okay, so I think there were a few topics that we wanted to discuss. Kin Fong, are you still there?
I think there are some questions also, which have come up, quite a few questions. So I'm trying to get that. You want to take up the questions on hemangioma first?
Okay. I think shall we just discuss the three cases first? So yeah. Dr. Wilsey's case on ulcerated hemangiomas. I think we do see that quite often. Kin Fong, what's your formula for treating ulcerated hemangiomas?
Pulse dilator, because my center do have pulse dilator. And then, of course, still put on propranolol. But in this ulcerated hemangioma, the duration sometimes could be shorter than others. So long as the ulceration recovers, sometimes we do stop earlier than the others indication.
In fact, I have a question here. What we observe also, patients with the ulcerated hemangioma and those without ulcerated hemangioma, when we are treating with propranolol, do you see a difference in the decrease, in the size and other parameters?
I think the main reason of the hemangioma get ulcerated is because first is the location of high humidity, high friction. Secondly is the enlargement of the underlying hemangioma faster than the epidermis, hence it become ulcer. So what we normally do is that when we have ulcerated hemangioma, propranolol can reduce the size of the hemangioma, and it does help in reducing the risk of getting ulceration, also healing of the ulcerated hemangioma.
Yeah, I agree. So usually I think there's a few new studies out at ISVA that have shown that the dose of propranolol required for ulcerated hemangiomas may not be so high. So you may not need to go beyond 2 milligrams per kilogram. The other thing I find quite useful is to start them on a short course of prednisolone as well. I find it heals up the hemangiomas faster. Sometimes I do start them on pulse laser as well. Yeah, so usually it's 3, and then of course good dressings for the ulcers. Yeah, my nurses love the honey dressing.
Even we do the lesser, start with a lower dose sometimes. So I was just wondering, and then of course we build it up, gradually.
Yeah, I think maybe the next case, Dr. Net's case on faces syndrome. So I mean, I think the question is, do you increase the propranolol as fast as non-faces cases, or do you do it slowly? Kin Fong, you have any thoughts on that?
I do start slower, but I do increase to the dose that I use for other form of hemangioma, so long as there's no obvious side effects.
So what if you do find some of these hypoplastic vessels or tortuous vessels on the MRI? What do you do with them? I mean, I usually manage with my neurologist.
Yeah, most of the time I just refer to my neurologist.
I think it's important to do that, but are you giving propranolol? I would probably refer them, to the pediatrician and neurologist and start in a lower dose. I think that is what is there in the studies also now, that it's started in the lower, maybe 0.3 milligram per kg per day. And then to be given 3 times a day, divided in 3 times a day. And we gradually build it up to a higher dose. But yes, we are skeptical. We do keep it to a lower dose as far as possible, or add on another therapy.
Yeah. Then Dr. Julie's case about the hemangiomas that don't respond to propranolol, what do we do? So for the second case, I've seen that before. So if you look at that second case, you can see that the contour is very, it's not smooth. There's that sort of, jutting out kind of contour. And you find that because the studies have shown that when you have that kind of contour, they sometimes do not respond to propranolol, especially if you don't start it early. So that nice round one, sometimes I refer them to the plastic surgeons. I find that they can cut it out quite nicely and do a purse string suture. And it turns out quite nice, the scar. Yeah. Kin Fong?
Yeah, I think if, let's say, they are not responsive, we are quite certain their compliance after you have increased to 3 milligram per kg per day, then depends on how strong is the indication. It's really indicated, then we do refer for surgical intervention.
Yeah. I guess can add on lasers as well if required. Yeah, but the thick one sometimes can be quite difficult.
Yeah.
Any other opinions from the others? We'll see Nanette, Rashmi, Surabi on these recalcitrant ones.
Yeah, exactly. If it is recalcitrant, let us say that after 4 weeks or after that. So maybe one way out is that, we do try, one option is, topical timolol or even atenolol. We've not had so much experience, but it is something that we have started using, that we don't have the FDA approval. And so far it looks to be almost the same as propranolol, but maybe that is one option we have, atenolol, which we can use. So I don't know whether you've had the same experience as we've had, regarding atenolol. Of course, then you have corticosteroids, but I would probably go in more for atenolol.
Okay. Shall we do the questions from the board?
Yes.
Yes, we have a few questions.
Can we take up the one from Dr. Bhumesh first? Up to what age we can give propranolol in infantile hemangioma? So would you like to take that up, Mark?
So I find it works best in the first 6 months when you start it. It can work in the first year. Beyond first year, I find that the effect is not great. I've tried definitely in 2-3 year olds, effect is not great. So you have to manage expectations, but it works well in the first year. So always refer early for treatment.
In fact, I worked with Dr. Ilona Frieden, and I think this is exactly what she had taught us, that the earlier you start, the better. Yeah. So if you start in the first few months, you get the best results. And as rightly pointed out, maybe in the first 6 months or so, but definitely not so much after the first 1 year.
Mm-hmm.
The second is by Indana Gautami. How long can we use propranolol? She's asked the other thing, that how long can you go on, with that? Maybe Kinfon or one of the other panelists can take that up. How long can you keep giving it? Is there anything like that?
You mean how long we can prescribe propranolol? So I think we prescribe propranolol according to the growth phase of the infantile hemangioma. If let's say those responsive, usually by 6 weeks to 3 months, you can see a very obvious improvement in terms of the color, the consistency, then followed by the volume. Once after 12 months of age, once you have achieved what you would like to achieve, then you can slowly taper it from 3 milligram to 2 milligram, then to 1 milligram per day every month. So usually this is what I normally do in my practice.
I think what's mentioned is mainly from studies, it is mainly between 6 months to 1 year at a go. But I think it is also your personal practice, what you like to give. So that's what is mentioned and what we do in our personal practice. Somebody's asked here, role of imiquimod in hemangioma, Dr. Lalwala Ishwar Lal. So are any of you using imiquimod in hemangioma?
Oh, with beta blockers, it works so well, we don't need anything else.
So expensive for imiquimod.
Yeah.
It is an option, definitely. One could think of it, but I think we have not used so much of it. But maybe worth looking into if it is totally non-responsive. Another question is from Dr. Shinu Goel, role of sirolimus. She's again asked about imiquimod. So most of us have not used it, but it's there as a treatment. Role of sirolimus in hemangioma.
I think sirolimus is well documented as an mTOR antagonist in conditions like lymphatic malformation, renal lymphatic malformation, as well as carposiform hemangioendothelioma. Again, has highlighted earlier on, since propranolol, atenolol are very effective and much safer, much cheaper, so we hardly consider sirolimus. And if you look at the mechanism of hemangioma, looks like it's not the right targets if you use sirolimus.
Yeah. So I think there's one question from Dr. Suresh. Is propranolol available in syrup or drop liquid in India? We know that it's available in the oral form. Well, I work in Kalavati Saran Children's Hospital that is affiliated to Lady Hardinge Medical College. We do have quite a big pharma nearby. And without taking names, they do dispense it, in a liquid or a syrup form. They make it and they dispense it. It is available. It is there. I think most of us buy it, from there and get it done from there.
So get
In
it
Singapore,
formulated.
is it available? Singapore and other places, is it available in syrup form?
So for us, we compound it at our pharmacy.
Okay.
Our pharmacy compounds it, but there's a commercial formulation called Hemangel, which is available in US and Europe, but it was too expensive to bring in, so we are just using the.
Yeah, compounding it is better, I think.
Yeah, in fact, there's a study show that it's stable up to 3 months if you follow the recommendation by self-compounded by the hospital.
Sure. No, we have this pharmacy, they do compounded. We're getting good results with that. Dr. Brito has asked, Doctor, what dose and which steroid did you use for this case?
Okay, which case was it?
Was it in any of the
Okay,
cases?
so anyway, I guess it's probably for the ulcerated case, right?
Yeah.
Yes.
Yeah, so usually if I start at the same time as propranolol, I'll give 1 milligrams per kilogram for the steroids and then tail it down over 2 to 3 weeks. I find it heals up the ulcers faster.
I think they're asking which steroid do you use actually for that?
Prednisolone?
Prednisolone, yeah, that's exactly what I thought. Do we have more questions? Okay, we've answered.
Yeah, one more question. One more. When or how do you decide that an infantile hemangioma is resistant to propranolol?
When you give, it doesn't work.
Like what duration would you give it for before deciding?
Usually propranolol works fast. So I would say probably, if you give and within a month or two, it's really
month and you get a response exactly in a month's time.
Yeah.
But when would we say it is resistant? Say 2 months would be fair enough.
If you've given a good dose, yeah. Most will respond within a month.
Typically they say that after 1 week or even a few days it works.
Yeah,
so
in 2 weeks,
that it
definitely you can see. But what I'm saying is that supposing we say this is resistant, when do we say it? I think after 1 month or after
1 to
2
2
months,
months.
because definitely after 2 months.
But one of the pitfalls is when you have a deep hemangioma, then you need to be slightly careful because you might need ultrasound to monitor the volume. The softening of the lesion also helpful, especially for paratic hemangioma. Sometimes it takes you have to give a longer duration, get an ultrasound to monitor the progression instead of our naked eye.
Yeah.
Okay. So I think we had a great discussion, and I do think that we will maybe revisit again sometime in the future to see how much people have understood. But it's been great, Some very fabulous cases, some very good lectures. And although I've heard some of them before, but they were still as enjoyable and informative. Thank you so much,
And thank you for all the presenters. And
all the presenters, Julie and Lynette and Wilsey and Kathleen,
all
Henrika,
the Asian countries.
And of course, everyone who has joined us tonight. Okay.
As well as even Ajanta Pharma. And I think now I see our Secretary General has joined us, Dr. Dinesh Kumar. Devraj, hello, Dinesh. So,
yes, ma'am. I've been following
thank you, Sylvia. I'm going to turn it over to you, Dinesh.
Yes, ma'am. And thanks a lot. It's I think this is one of the program which generated a lot of interest among our members. And I could see that I was getting a lot of inquiries and a lot of people were evincing interest on how to attend it. And they were pretty much, I think they would have benefited a lot given that the scientific program has been so well curated that it has covered everything right from clinical practice and academic interest. And we have had such wonderful speakers with us today that I'm sure our members will be wanting more programs in the future. And this being the president's initiative coming the International CME in association with the Asian Society of Pediatric Dermatology. We are very happy the way it went along and the interest it has generated and the amount of benefit that our members have gained out of this thing. So I would like to thank all the speakers who have taken out their valuable time and shared their knowledge and experiences with us. Thanks a lot. And we do hope and request that you continue your association and with IATVL and continue to benefit us in a mutual manner. And I would also want to thank all our members for attending the program and giving us the enthusiasm and encouragement to move on with such programs. And most of all, I would want to thank the IADVL Leadership Pipeline Committee. They have been wonderful, and they have been always on the toes, generating many such programs. And my most important thanks goes out to my president. She has been a very good source of inspiration and a very dynamic president, hands-on president. So she's conducting a lot of such programs. So and lastly, Ajanta Pharma, yes, they have been supporting us, and many other pharma industries also in our initiatives in this Golden Jubilee. Thank you all. Madam, would you want to add
Can
something?
we take a quick picture? Yes, a quick picture, because you were
Sure,
not there. Can you please put on your cameras, please? Can I request everybody to please switch on the video, our speakers, because Dr. Dinesh wasn't there. So if we can just do a quick picture.
Yes, doctor. Request Dr. Young Cho, Dr. Seema Nair to please.
Seema Nair need not put it on, but Young Cho. 1, 2, and 3.
Okay.
And
okay.
and don't forget to join ASPD as well.
Yes, and also the RSMPT next year.
Yes,
in
we'll all
New
be
Delhi,
there.
November. Yeah, so it's going to
Okay.
be great.
Thank you.
Thank you, everyone.
Thank
Have
you.
a good night.
Thank you. Good night.
Thank you.
Thank you. Good night. Good night.
Thank you. Bye-bye.
Bye.